Dr. Chow speak, what do I have now? You know, the bar is like really high, so I don't know what to do now.
So you better perform, I guess.
I will give it my best shot. I don't make any guarantees. We'll see. But that's why Dr. Chow is going to come back later and to wrap it up a little bit more. So my name is Maria Carrillo, and I'm manager of behavioral health services at Optima. And I work closely with Dr. Chow and figuring out strategies that helps us support the integration of primary care and behavioral health services. So we're always looking, we're always thinking, what can we do? How can we support this? How can we do this initiative to be able to take one step further on the integration? As you know, right now there's a lot of fragmentation. The doctor, PCP, the doctor is at his office, the behavioral health psychiatrist or physician is at his office, and there's not a whole lot of communication going on. We don't know that our body is attached to our head. We're the same person. So we want to bridge that gap. So those are one of our initiatives, our strategies that we're trying to do here at Optima. But enough of that. I will just cover a little bit of the history of parity. Dr. Chow already did an amazing job of really giving a background as to what is parity and what should we expect from it. As you all know, there are gaps in coverage. There are gaps in coverage for health insurance for mental illnesses. There's limited benefits, there are limited services, there are actually a cap on the minimum lifetime benefits for mental health services, and also several increases in premiums, which make it a little more challenging to be able to receive this mental health services. So what have we done? What has the legislation done? Well, this mental health parity legislation responds to this gap, to this disparity. And what they are trying to do is really make it a par, make it so that, as Dr. Chow said, if you're going to get a mental health benefit, it should be measured the same way as you're measuring a physical care benefit. So now I feel like the mental health benefits are really not going to be the red-haired stepchild anymore. We are going to get support. So we are really excited for January 2014 because there's going to be a lot of exciting changes at the time. So, changes. Okay, history. At the end of the presentation, I want you guys to remember the laws. There'll be a test, there'll be a quiz. I'm kidding. Actually, again, the government has listened. They are aware, they know that there is a problem, that there is something that needs to be done. The first one was in 1996, which really addresses the issue with annual aggregate lifetime dollar limits, as we had said before. The next one, California, we're not that far. In 1999, it's been a little over a decade, but we're going in the right direction. So it's adding a little more protection for mental health benefits. It's really trying to move in the right direction. And the last one, of course, in 2008, it expands the scope of mental health parity requirements at the federal level and also includes substance use disorders. So my takeaway from this slide is pretty much that, there is legislation, it's been slow, it's getting there. Something is being done, and we definitely look forward to January 2014. Now, benchmark mental health benefits. What is that? The state of California has selected Kaiser Small Group Products as the benchmark plan, which this means is that any other health organization, health insurance is going to have to provide at minimum the same type of benefits that this plan is going to offer. It's going to be pretty comprehensive, so this is what we are going to be looking at. This is going to be our standard, our minimum, our benchmark, however we want to say it, but that is going to be it. So this benchmark plan is going to have, the evidence of coverage, which is going to include a broad range of mental health disorders. Currently, there's a lot of limitation as to what mental health disorders are included. Very limited, let's say severe schizophrenia, for instance, and nothing else. So with this, what this says is that the DSM-4-TR is going to be utilized, and if the person meets the criteria for diagnosis under these conditions, then it's going to be a disorder that will be included on this benefit. Again, coverage will not be limited to specific list of conditions or diagnosis. I like that. Isn't that cool? Yes.
Well, just a question about using the DSM-4. Why wouldn't they use the DSM-5?
Because DSM-5 is not out yet.
So when it does, it'll update.
That's correct.
Okay.
Everything takes a long time. Don't tell anybody. But we're excited. We will be also looking at DSM-5, but that's down the road. But for now, it's the DSM-4-TR that is going to be the framework for mental health diagnosis, which will be included on this mental health benefits. All right, so there are three major categories of mental health benefits that are going to be included on this benchmark plan. I will start with this one, but I'll give you a hint. It's outpatient services, inpatient services, and substance use disorders. It's huge. We are excited.
Job
We're
security.
excited. One, job security. Number two, substance use disorders really hasn't been given any attention. In addition to obviously mental health disorders. So with this, health insurances are going to have to cover this as part of their benefit package, which is awesome. My current health insurance doesn't cover any of that, and sometimes after I drink, I want to go there. Okay, so what's included on the outpatient mental health benefits? Your basic, your typical individual assessment and therapy, or group as well, group therapy. It also includes psychological testing for necessary additional diagnosis. And also, this is a very new one, the outpatient services for the purpose of monitoring drug therapy. That's a pretty interesting one too. So, as a licensed clinical social worker, I see this and I'm excited because I know that you need a combination sometimes of individual and group therapy to address the issues of mental health illness. Sometimes someone can benefit from individual therapy, that's fine. But there are some diagnoses that can actually benefit from group therapy. Why? Because we know that when you hear from a group and you understand and you're listening to other experiences, there is support there. There's learning, there's growth. So this benefit, I think, is going to be huge. In my humble LCW opinion.
My question is okay, we're doing the evaluation and the treatment for outpatient services. So how are they going to keep track of that if the patient's only going in once a month? This is, I mean, I see it every day where without a PSC and without constant contact, a lot of people forget, don't show up at their appointments. I've done it myself. And so how are we going to keep track of this through the evaluation process if the patients ain't even showing up and they don't have no care coordinator to even help them or assist them?
That's a great question. It's something that is broad in our community. It happens in the physical care world. It happens in the mental health care world as well. Mm-hmm. When I was practicing, I will have my assessments, and I was doing assessment, therapy, treatment group as well. And we will have a fairly normal no-show rate for one reason or another. But one of the things we try to do is really outreach to this person and address and identify what are the barriers, what are the things that are preventing you from getting to this appointment. So when mental health services are going to be included in this benefits, mental health clinicians are the ones who are going to be providing these services. So by training, we are able to reach out and really connect with the client and identify those barriers.
One of the requirements for benefit is the care coordination piece, and it's very general in care coordination of all health. It doesn't spell out just mental health, but
right.
They just assume that it's under that.
Okay.
Folks understand the last bullet point there, though? Do you understand what that means? So that's our psychiatric services for psychiatrists.
Mm-hmm.
Thank you, Dr. Chow.
I have one other question real quick. With a lot of the consumers with having a substance abuse problem, say they're on medical marijuana, for instance, or they're doing pain management, and they're self-medicating themselves on top of the psych beds, how are you guys going to evaluate that?
That is something that okay, Dr. Chow will be happy to answer that question. So I guess I need to move forward. So to make sure that we all get to all the information. Inpatient benefits. Wow, look at that list. It's pretty good. To me, that's exciting because you're obviously if the need arises, and from time to time, we might need that benefit to be there available. Nowadays, it's very limited. So you will find inpatient psychiatric hospitalization, short-term based, hospital-based intensive outpatient treatment, short-term multidisciplinary treatment and intensive outpatient psychiatric treatment program, residential, crisis residential program, obviously that covers all the whole gamut of services. Psychiatric observation for acute psychiatric crisis. So I think it's a very comprehensive. It covers a broad range of services depending on where you are, on where the client is, and what the needs are. I'm sure, we will want to make sure that a person receives the services at the right place at the right time. Let's say somebody just needs intensive counseling and is taken to a psychiatric hospital and lockdown facility. Does that make sense? No. So I think that's why the initial evaluation is important so that they're able to form a proper care treatment plan.
So if Laura's Law is put into effect, how is this going to implement the inpatient services through?
Speak to Laura's Law.
No, it doesn't?
Because remember, this is federal law.
Okay.
Laura's Law is just California.
Okay.
And the next one, substance use services. This will definitely cover outpatient chemical dependency care. It'll have day treatment, intensive outpatient treatment, individual and group therapy, again, which we know that is beneficial. But when there is a higher need for more services, when the person alone is not going to improve or meet his or her goals in recovery, there's going to be additional benefits, additional assistance that is going to help. Medical treatment for withdrawal symptoms is going to be one of those. Medicine maintenance for pregnant members during pregnancy and for 2 months after delivery. Again, that is only going to be offered during pregnancy and 2 months after delivery. That's one of the caveats on that. Inpatient detox. That's another one that right now it's a little fragmented and complicated to access. It's a little challenging, but with healthcare expansion, this is going to have to be a benefit for all health insurance plans that accept these members. The other one is transitional residential recovery services. Again, high need in this population. I think